So, welcome to our fourth journal club presented by the FSHP Medication Safety Council. Just so you know, the first three journal clubs can also be viewed by going to the FSHP website and then under events and education and then education resources. We give you the link to the YouTube videos for those presentations. Unfortunately, they are no longer eligible for CE credit, although they do contain a lot of good information. As a reminder, tonight CE is valid for live CE, unfortunately is not valid for the medication safety CE as it's not a 2-hour program. Information for claiming your credit for the continuation approach will be sent to your email later this evening. And we also hope to see many of you at FSHP Annual August 4th through 6th at the beautiful Gaylord Palms in Kissimmee. I'm pleased to be able to introduce our presenter for this evening, Kevin Martin. Kevin Martin is currently the Pharmacy Operations Manager at Jackson Memorial Hospital in Miami, Florida. He graduated pharmacy school from the University of Florida College of Pharmacy in 2018 and completed a 2-year health system pharmacy administration residency at the University of Iowa Hospitals and Clinics in 2020. And take it away.
All right, thank you, Timothy. So I'm really excited to be presenting today on today's journal club focusing on paralytics. I'm anticipating a lot of great discussion, especially towards the end of this presentation. The presentation is going to focus in on the Redonda case that many of you may be already familiar with in 2017 that took place in Vanderbilt. And the ISMP recommendations around that. The disclosures, I have no disclosures or financial interest to disclose at this time. The objectives for today's presentation, so I'm going to describe the medication safety concerns present in the VOC case, understand the safeguards institutions have in place for high alert medications, and identify additional practices that can be put in place after the paralytic error that occurred in Vanderbilt. In order to really get a good idea of the case, it's important to understand the patient case prior to the error that occurred. So I'm going to give you all a brief timeline of why the patient had been in the hospital. So the patient was admitted into the neurology intensive care and an MRI confirmed an intraparenchymal hematoma. The patient was pending transfer to the step-down unit, but prior to that transfer, the physician wanted to get a PET scan on that patient. So the patient had been sent to radiology for that PET scan, and that during that time that they were explaining the scan procedures and what was going to be happening, the patient got very anxious about and felt that she was going to be very claustrophobic in that space. So then at that time, the physician had ordered IV Versed, generic midazolam, 2 milligrams to be given to the patient prior to the procedure. This order had been entered in the system and verified by the pharmacist within a few minutes. So then the question after the order has been put in is who's going to administer this patient? So the patient had already been taken down into radiology. So should radiology staff be the one to administer this medication? However, the radiology staff felt that this really is outside of their scope. They really are focused on giving contrast and doing the procedure, and they don't have any of these sedation medications or anxiolytics in their reach as well. So they had reached out to the primary nurse for this patient that was in the neurology intensive care unit. However, during this time that she was busy covering another patient's nurse, so she had contacted the help all nurse, which is a nurse that floats and is there to help as an additional set of hands for situations like this in which a nurse wouldn't be able to get away from their patient and help that nurse with any tasks that they may need. It's important to note that this help on nurse was also very busy. She was orienting a new nurse at that time and was going on her way to the ER to conduct a swallow study on a different patient as well. But she did agree to administer the IV Versed to the patient, and so then she went to the neurology automated dispensing cabinet, the one in the ICU, and could not find Versed listed under the generic name medications, because the way that the automated dispensing cabinet was set up is that you have to toggle between both brand name and generic name. So it was in the generic name functionality, but she was looking for the brand name Versed by typing VE, and no medications had come up. She had mentioned later on that there was a lot of issues with they had recently had an upgrade to their electronic medical record, Epic, and there was a lot of delays in orders being transcribed from the system into their automated dispensing cabinets. So then she didn't think much of this, that she couldn't find the medication in the patient list, and had gone into the override functionality, still under the generic list of medications, and typed VE. She was talking to a fellow coworker at this time, and while pulling out the medication, vecuronium was the first medication that came up on the list. She assumed that the first one that would come up is Versed, clicked on that, and pulled it out. She noticed that it was in powder form. Usually she was a very experienced nurse. She knew that Versed, midazolam, comes as already a liquid in the liquid formulation, but she didn't think much of it because of a recent hurricane had caused a lot of drug shortages in that for their hospital. So she had thought that this was just another medication that had gone on shortage, that had caused a change in the formulation of how the medication was provided. So she had gone and read the reconstitution instructions on the vial, not noting that the vial actually read as vecuronium and not midazolam, and prep the medication to go to radiology by getting the normal saline that would be needed to reconstitute, and putting all the supplies in a plastic bag to go to radiology to administer what she believed was IV Versed. So when she got to radiology, the patient had been moved to radiology holding, where they had already received their contrast and was waiting for that to be absorbed. And so the nurse had verified the patient information and made sure she was giving the medication to the correct patient, and reconstituted the medication with the 10 mLs of normal saline that she drew and that she read that they needed, and drew the reconstituted medication to be administered. She did not notice at that time, or at least misunderstood, the warning on the vial top that reads warning paralyzing agent, and she administered an unknown amount of quantity of IV vecuronium to this patient at that time instead of IV Versed. After administering the medication, she went to the ED to conduct the swallow study. So she, even though she gave a mild sedative to a patient, she did not stay to monitor how the patient was going to be reacting to this medication. And so she left them in this room. There was no other staff members in this room. It was being observed. The holding area is observed by a radiology technician via a camera. The radiology technician noticed that the patient's eyes were closed. However, they thought that the patient was resting. They did not, from the camera, could not tell or see that the patient's, if their chest is rising or not. So at that time, they did not notice that the patient was actually not breathing after being given a paralytic. And the patient stayed there unresponsive for about 25 to 30 minutes until a transporter had come into that area and noticed the unresponsive patient. At that time, a code was called on this patient. They were intubated, and they eventually regained spontaneous circulation and were taken back up to the neurology ICU. However, after several days, their brain function was not going to be compatible with life, so they ended up passing away due to severe brain damage, and they had to remove life support from this patient. The error was discovered when the help-on nurse returned from the ER. She had saved the vial of the vecuronium for this that she had administered, because believing that it was IV Versed, she knew that Versed had to be wasted with a witness. So she had saved that the vial and the supplies that she had taken in order to get the primary nurse to witness the waste with her. At that time, when she gave the vial back to the primary nurse to act as a witness, that's when the nurse noticed that the medication was actually vecuronium and not Versed. And then at that time, the physician was notified and this information was disclosed to the patient's family. So a very unfortunate case in which a lot of choices really led to this error happening. And so we will go into recommendations that have come out of this case for the hospitals, as well as things that could have been done differently. But to begin, I think it's important to really understand how medication errors impact us throughout the country. So just to have a general idea, there's about 100,000 medication errors reported to the FDA annually. And about 44,000 to 98,000 medical errors in the US result in death. 7,000 medication-related deaths happen annually. There's a 1.5 million preventable adverse events per year. There's about additional cost of about $17 to $29 billion each year due to medical errors and medication errors. And there's an average increase in admission of about $4,700 to about $8,750 per admission for medication errors and medical errors that occur each year. And so this is a diagram that's a modification of the Joint Commission's medication management system. And it really shows that medication errors can really happen at any point in the medication management system, whether it be planning, selection and procurement, storage, the patient's admission, ordering and transcribing and reviewing, preparing, dispensing, administration, monitoring, patient discharge, and evaluation. And we see a lot of these points are actually touched upon in this patient scenario, from the ordering and transcribing, which I mentioned, there was delays a lot in the orders from the electronic medical record going into the automated dispensing cabinets. And so that really leads to a practice in order to prevent delays of medications having to constantly be overridden. So that really impacts your dispensing, administration of the medications. So focusing on the 5 rights, which I have a slide on late after this as well. Monitoring of the patient. So if you're giving a patient a medication for sedation, you want to make sure that you're monitoring them and having those in policy, and how are patients being monitored, and what needs to be documented. And so we see points of this medication management system in this case and this medication error that just occurred. And so when we think about the 5 rights and whether ritonavir follow these 5 rights. So we want to make sure every time that we're giving a medication to a patient, it's the right drug and the right patient, the right dose, the right route, and the right time. So she didn't have the right drug. She did make sure she had the right patient. However, with the wrong drug, it was the wrong dose, given in the right route, and definitely not the right time for this to occur, because any paralytic that needs to be given, you need to make sure that you can immediately intubate the patient. So from this, ISMP has recommendations for automated dispensing cabinet safety features in order to reduce the risk of errors when removing medications from a cabinet. And so they start off by saying to optimize profile automated dispensing cabinets. So ensuring that medications are being removed under the patient's medication list, whether there's the scheduled list or the PRN list, and not going under the override functionality, and really limiting the amount of medications that can be removed on override. So managing that override list to only medications that are defined as urgent or emergent in certain situations. And then you want to really review what's loaded in various areas and block staff from loading inappropriate medications, especially when we think about our high risk, high alert medications. We don't want those inappropriately loaded in areas that aren't equipped to administer those medications, or in an area that they could be used in error. So utilize warnings during medication removal, and really that's it's a double-edged sword, and you have to be very careful about the alerts that you use, because you don't want to create alert fatigue at your automated dispensing cabinets. But I think they really make a good point here of making it a purpose, making it a question in which they have to answer. So not something that they can just acknowledge and say, okay, but saying something of having to select the purpose of the drug removal, having to state whether the patient is ventilated or not, if it's a neuromuscular blocker. So make it a question that has to be answered, and not just an acknowledgement that there is a pop-up that they had to exit out of. Having witnesses for override medications, so that they can verify the correct patient medication strength, route, and indication when an override is being conducted. Allows simultaneous searching by brand of generic names, so that way the staff doesn't have to know whether they are typing in the brand of the generic, but it will come up on the same screen regardless of which version of that they are typing. Support distraction-free automated dispensing cabinet medication removal, because like I mentioned, in this case, she was distracted during that medication removal, which led to her selecting the wrong medication and not realizing it down the line. Limit access to medications, especially this is focusing in on neuromuscular blockers specifically. So limiting those to perioperative labor and delivery, critical care, and ED settings, and having them in a sealed box, an RSI kit, or in a lock-lidded ADC pocket. And then affix a warning in the ADC pocket that will read a warning: causes respiratory arrest, patient must be ventilated. Along with their automated dispensing cabinet recommendations, they also have other recommendations specific to paralytics that came out in response to this case as well. So they say to establish a standard procedure for sedations prior to radiology procedures. So whether that's having them built into those anxiolytics built into the order sets in order to have them given prior to them going to the radiology, how are those patients going to be monitored, having that clearly defined. Include medications used for moderate sedation on your high risk, on your high alert medication list. Eliminate storage of neuromuscular blockers in areas where they are not routinely used. And I will say that's something that you don't want to just do once, but it's constantly having to check where your neuromuscular blockers are being stored, and making sure that we're constantly checking that, because even though you may do that, have the exercise of checking all your paralytics and where they're stored, we know that in a hospital setting, units close down, ICUs get moved. During COVID, we had several med-surg floors acting as ICUs, so they would have in their automated dispensing cabinets different paralytics that necessarily they would not need after they are now no longer a COVID ICU, but are a regular med-surg floor again. So since areas are constantly moving, and healthcare and hospitals are such dynamic places, you want to make sure that you're not only checking your muscular blockers and thinking we're good, we've got this covered, but going back and revisiting that on a frequent basis, defined by a policy, most likely would be the best strategy. Place auxiliary labels on all storage locations. Place interactive warnings, in which, like I mentioned, they would have to answer the question on the ADC screen that interrupts the removal, so that it really prompts them to read and think about what they are removing. Clarify hospital override policies and limit permitted use to emergency or urgent situations. Avoid unjustifiable overrides by limiting overrides by medication, users, and cabinets. So your override list that you develop may not be the same that you for an ICU, as it should be different for an ICU as it should be for a med-surg, as it should be for pediatrics. So depending on what your patient population is, really defining what overridable meds there are, and having specific criteria on why those medications should be overridden. Require witnesses prior to the withdrawal of certain designated medications on override. I think it's important to note too, in an emergency situation, it may be difficult to have two nurses go to the automated dispensing cabinet to act as a witness. So really, I think the most important thing to note here is designated medications on override, and not all medications on override, because that could lead to potential delays if all medications on override require a witness. And then monitor your ADC overrides daily to ensure that they're being reviewed, and that the overrides are appropriate. And then for us at Jackson, we actually present those in our med safety meetings to the health system as well, to show our trends and follow along to see how many medications are being overridden, and for the frequency, and as well as seeing why. They also recommend prior to administration, verify each medication via barcode scanning to ensure accuracy. Require that patients monitoring for IV sedation and specify parameters in the hospital's policies or guidelines. You want to avoid distractions and talking at the ADC while searching for and withdrawing medications. Teach practitioners to access medications from the ADCs in the profiled mode where possible. So if you're in an inpatient unit that's with profiled orders, utilizing that profiled mode instead of the override or stocked meds functionality on their automated dispensing cabinet. And adopt a just culture. So a hospital has many policies and procedures. These are just some that we see that can really help and prevent errors. So whether it be your waste program in order to ensure people understand hazardous waste, controlled substances and preventing diversions. But really in this case, focusing in mostly on your override processes, ensuring that you have policies and procedures in place, override lists, limiting the amount of medications that need to be removed on override. If there are a lot of medications being removed on override, asking why and fixing those in order to have those medications then being removed in the profiled settings. The reviewing your high risk, high alert medication policies, and what does it mean for prescribing those medications, administering those medications, storing those medications, and having all that laid out in the policies and procedures. And then same with look-alike and sound-alike medications that may have similar names, similar phonetic sounding names, may look alike based off their vials or tablets, packaging, making sure that you have strategies in place in order to prevent errors with those. So from this case, when Vault was on trial, this is a quote that she had, so I wanted to share with all of you. So overriding was something we did as part of our practice every day. Vault testified to the nursing board. You couldn't get a bag of fluids for a patient without using an override function. So really, they had, like I mentioned, after their upgrade of their electronic medical records, such delays in the medication orders being transferred over to their automated dispensing cabinets that they had been told based from Vault that they should, in order to not delay care, remove medications on override whenever they need to, not based off of medication list, not override list, not only for emergent situations. So overriding was a way that they got their medications very frequently. And so it really creates a culture in which an error like this could happen due to the extent of overrides and the override practice being so widespread throughout the institution. And so when we dive into high alert medications, high alert medications are drugs that bear a heightened risk of causing significant patient harm when they are used in error. Although mistakes may or may not be more common with these drugs, the consequences of an error are clearly more devastating to the patient, which is clear in this case as well, that this patient had a very severe outcome, which ended up in death. So we have strategies here to minimize harm, especially with high alert medication. So you want to standardize your ordering, storage, preparation, and administration of these medications in order to have them standardized in order to prevent errors whenever possible. Whether that be building in order sets in which orders are already have parameters in place, having those medications stored not only within like the automated dispensing cabinets for paralytics with the alerts, but within your pharmacy. Make sure that they are not intermixed with other medications. They are separated out. They are properly labeled. Staff know that they are high alert medications. Preparations of these medications and administration of these medications. So having alerts throughout the process to ensure everyone is aware of these medications. And regardless if you think that you've educated, there's always new staff coming in, new technicians, new pharmacists, new nurses. Now that we're in July, new physicians as physicians are starting in their residencies. So you want to really be employing lots of redundancies because you never know, even though you may feel like you've done your due diligence in education, new staff is constantly coming through, as well as old staff may become so used to seeing these medications that they forget or do not remember that the real harm that could happen from their role in throughout the process, the medication management process, especially with these high alert medications. So you want to improve the access to information for these, limit access to high alert medications. So really taking a look at where they're loaded. Do they need to be there? Is the staff trained to be there? Having that in policies and procedures. Where can you give, where can paralytics be administered? Or where can you give hypertonic saline, and you should not have it in other areas if it cannot be administered there, because then it could end up being administered in error. Employing redundancies, like I said, and providing mandatory education. ISMP, when this error came out as well, has come out saying about how to search medications in the automated dispensing cabinet. And their recommendation is for 5 characters, which the strength that they have for this is that you're less likely to select the wrong medication if you're typing 5 characters of that medication. However, I think that there are various weaknesses, opportunities, and threats that I also felt like we should have a discussion about in this presentation, because especially like looking at the weaknesses, there's a potential for misspelling the first 5 letters, so then it's difficult to find. There's difficulties in locating combination drugs or parenteral fluids, entering spaces or symbols to meet the 5-character requirement, and then difficulty locating drugs known by several different names is also a weakness. So for threats, and especially in emergency situations, it could be hard. The nurse may fail to find the medication, or they might forget that they have to enter five characters, and so not seeing anything come up. They'll end up scrolling, so bypassing the searching functionality, scrolling through the entire list of drugs in the inventory would have a higher potential of selecting the wrong medication. And then nurses may end up also storing medications elsewhere in order to have for emergency situations. So then you have unsecured medications being stored throughout the floor, throughout the unit, because they know that it can be very difficult to access those medications during an emergency. And so they end up storing them elsewhere in order to have them for those emergent situations. And then some opportunities. So it's reasonable to create some aliases or synonyms, especially for those medications that are known by several different names on the override list that are commonly known by the different names. And so ISMP also came out with an FMEA on the 5-character drug searches. And here they have a lot of the possible consequences. So they have it listed based off the potential risk points and then the possible consequences that may occur. So the possible consequences being unable to find the desired medication, selecting the wrong lookalike medication, delaying care, looking up the drug in the reference, trying another automated dispensing cabinet, thinking that it was just not loaded in that one, so taking longer to find the medication, calling the pharmacy to have somebody bring the medication as a stat because they weren't able to locate it within the automated dispensing cabinet, asking somebody else, pulling them away from the emergency situation as well, asking them for help in finding the medication, not secure, not having those medications stored in the automated dispensing cabinet. So then you'll end up missing erroneous or absent drug charges, and then drug unavailable for another purpose. So I think there's a lot of great information in this FMEA, and it's a very big risk versus benefit when we talk about implementing the 5 characters, and that's really a huge discussion point among various hospitals right now. is how to implement this in a safe manner and working with nursing leadership in order to have accomplished this, even though ISMP does recommend, say, all these possible consequences. They do, in the end, still recommend the 5 characters due to it being a safer functionality for searching, but it really does take a lot of intentional build inside your automated dispensing cabinet, ensuring that things can easily be searchable by the aliases or the various names, or especially when you think about your potassium with fluid, how are those going to be listed? Or those medications that do not have, that are not 5 characters fully, how could those be found? So having strategies for those and working with nursing in order to make sure that it's a smooth rollout and it's not something that you can just turn on. Another aspect of this case that we talked about earlier when we went through it was the failure to barcode scan upon administration. So the patient was identified. They were able to, she was able to identify who the patient was, but she did not use barcoding in order to scan the medication prior to administration. If she would have done so, she probably at that time would have caught that the medication would not have scanned as Verse said, and it was, she could have seen that it was the wrong medication. And so barcode scanning really can help us preventing errors in various different aspects of the medications process. So it could help us make sure medications are tracked and sent to the correct place, ensures that the correct medication is added to an Omnicell. So whenever the pharmacy staff is refilling or the nursing staff is returning to the Omnicell, having that barcode scanning functionality enabled in order to ensure that the correct medication is being added to the Omnicell and not being put in the wrong location. And then when we're filling or pre-packing, it also ensures that the correct medication is being packaged. So it's important to utilize barcode scanning throughout our system, not only when we're thinking about BCMA, but even within the pharmacy. There's lots of opportunities for incorporating barcode scanning in order to ensure that we have a safer process. And then along with the recommendations, the FDA has also asked manufacturers to add the statement warning paralyzing agent in red bold font to the principal display panel on the carton and the container label. And they also asked the manufacturers to add a statement on the side panel that reads, warning paralyzing agent causes respiratory arrest. Facilities must be immediately available for artificial respiration. So this came out because of this case. I know that during the COVID time, there was a lot of concern because since the use of paralytics had increased so drastically, a lot of these manufacturers couldn't keep up and ended up putting out a statement that a lot of these warnings were not going to be printed on the tops, which is a major safety concern when we think about the products that we were using constantly and had widespread throughout the hospital that are high risk, high alert medications that have a high potential for error. So, but now that the COVID wave is done, I've noticed that those have been back, so hopefully they're back for good. And the last recommendation that ISMP had was to incorporate a just culture. And so what does a just culture mean? And here we have the various different types of culture that exist within a hospital setting. So you could have a punitive culture in which severe outcomes for errors, there's severe outcomes for errors, and this really leads to individuals hiding errors and shifting blame. So instead of really determining the root cause of what happened and how we can fix and prevent an error from occurring, we are simply blaming the individuals that caused the error and shifting blame to other individuals. there's what we call an unfortunate outcome. So in this type of culture, you never really uncover errors, and you're really due to repeat your errors because everything is deemed just an unfortunate outcome, and there's no investigation on the true root cause of why that outcome happened. There's the blame-free culture, in which you don't blame workers. There's amnesty for all. And this culture really leads to a lack of accountability because it leads to individuals not following policies, not following procedures, and you're going to end up continuing to have individuals not following those procedures and errors to continue to occur. And then there's a just culture, which is a combination of both punitive and blame-free. So it's somewhere in the middle, which is where we would like to be. And it values safety in the organization, and it really evaluates whether the events happen because of system problems or risky behavioral choices. So here are the different types of errors, behaviors that can lead to a medication error. So first, we have a human error. So these are inevitable, unpredictable, and unintentional errors. We do not choose to make this error. Some examples include incorrectly programming a new infusion pump following the directions used for an older pump, prescribing an excessive dose due to a knowledge deficit about a patient's recent weight loss. So those are not errors you mean to make. Then you have at-risk behavior. And so in these, you're mistakenly believe that the risk is insignificant or it's justified. So your behavioral choices that are made when individuals have lost the perception of risk associated with the choice. So you're drifting away from strict procedural compliance and developing unsafe habits. For example, programming an infusion pump outside the drug library or removing medications via override outside of an emergency. And then we have reckless behavior. So this is a conscious disregard of a substantial or unjustifiable risk. And individuals who behave recklessly always know the risk they're taking and understand that it is substantial. They behave intentionally and are unable to justify the behavior. And some examples of this are drug diversion, retaliatory breaches in patient confidentiality, or performing job duties or procedures under the influence of drugs or alcohol. So now that we understand what a just culture is, the question comes up for Vaught, is what she did criminal? Was she acting recklessly, or was it a human error or at-risk behavior? Was she simply drifting? So here we have some of the choices that she made. She chose to obtain the medication via override, due to the circumstances that seemed to be common practice at the institution that she worked at. She did not confirm the drug at the dispensing cabinet nor at the time of administration. And she chose not to monitor the patient after administration of this drug, which is a minor sedative. But the question now, so did she do this knowing the risk of her decisions? So the Institute of Medicine has stated that to err is human. Healthcare systems are responsible for a high prevalence of medical errors. The complexity of medicine leads to many opportunities for mistakes to occur, and improving patient safety and reducing medical errors must occur at every level of the system. However, David Marks says to drift is human, and I think that's a more accurate representation of this case. And he gives a good example of when you're driving down a highway, you're going 9 miles over the speed limit, focusing in on your audiobook, you do not, changing lanes without using your indicator, you do not see the risk in your behavior because you are so used to this drive, these actions, you are not thinking you're putting yourself or others at risk. However, if you see somebody going 30 miles over the speed limit, swerving through traffic, that you would consider as reckless behavior, even though both of you may be not following the laws of the road. One is more conscientious. They are choosing to go way above the speed limit and weave through traffic, while you have drifted away from the speed limit, knowing that you are at a safe distance away, that you can still go back down and feel that you can still manage that, even though it is above the regulatory speed that you should be going. So really, Vaught had been a nurse for so many years. She her actions were not reckless. She had just simply drifted from what she should have been doing. Like I mentioned in the beginning of the case, she was orienting a new nurse during this whole time. So if she was orienting someone, why would she choose to do reckless activities? Why would she choose to take the medication back to be wasted? But it was simply the choices that she made are choices that she made every day, likely. But it's just that this day it ended up being that it cost somebody their life. So after her case, she did end up being found guilty under criminal charges. And so ISMP spoke out against criminalization of medication errors. They are very adamant that the jury was not presented enough evidence. The truthful reporting that Redonda Vaught, she was very cooperative, very truthful testimony, and has really fallen into the category of the second victim. She is very remorseful for what happened, and did not mean for that outcome to happen. And so she was very cooperative, and that was used against her in order to try her and make her look like the guilty party. It was an unfair trial process in which it did not reach a just outcome. This fatal error should have been prevented. The trial was offensive, and the trial will have a severe impact on error prevention. So what we have seen from this, and I know we've seen it within my health system, there's an impact on reporting of events. So people end up being scared to report events because now there's a fear of criminalization if an event happens, if it is reported. We see a lot of nurses leaving the profession due to the fear of being tried under criminal in a criminal case for actions and for an error that they do not intend to make. And nurses feel unsafe practicing. They feel like they any small mistake that they make could end up costing somebody their life and could cost them their profession. And so that's why a lot of nurses are leaving, and we saw that especially during the COVID time too. But we still are seeing a high volume of that fear from this case specifically. So here are my references. And now I know I covered a lot of intricacies of this case, and I would love to open it up to the group for a discussion or questions about thoughts about this specific case and paralytics and safety and how to make our health systems a safer place.
Thank you. There's a lot to unpack there. You could probably have a 6-hour seminar just on this case, everything that happened, and everything that has come out of it, and again, healthcare as a whole, kind of learning from mistakes.
Yeah, for
If
sure.
anybody does have questions, please just place them in the chat and I can read them out. I think everybody's muted, so. Or if you're feeling brave, you can unmute yourself.
Hello? Hi, I do have a question.
Go ahead. Oh,
So, Dr. Kevin, thank you for this presentation. My question is, even though there are different barriers for the nurses to administer medications, for example, you mentioned barcodes, there is still a reality that sometimes the nurses, because of time pressure or the number of patients, they still override the barcoding in the patient, or they give the medication to the patients even before a scan the barcode into the EMR or anything like that. What are your thoughts on that? I feel that there might be some room for improvement and for patient safety.
For sure. I know at our institution, we as pharmacy, we do audits of like barcode medication administration to see compliance. We have a dashboard of like units that are very compliant and units that are not very compliant. And then we're also able to compare users to each other. So I think that's very useful because it helps to compare apples to apples. So if you're seeing like one unit is really failing at barcode medication administration, why is that? What makes that unit do worse than another unit? And you can dig deeper into those barriers. Is it patient load in that unit is higher? Is it that they have, is pharmacy doing, do we have things in their automatic dispensing cabinet that doesn't have barcodes, so then they can't end up scanning it? So those are some things that we end up finding out by looking deeper into the data and really comparing users. However, what we end up finding, at least most recently, is that we have really great performers on certain units and then really bad performers. And so why, then you have to ask the question, why do some users perform so well and other users not perform well? Is it the users, is that user drifting, right? Have they been a nurse for so long that they lost sight on the importance of barcode medication administration or barcode scanning prior to administering the medication, and having those conversations and coaching? Because in a just culture, you don't want to just wait for the error to happen. You want to continue to monitor in order to catch those behaviors, those at-risk behaviors earlier on, in order to prevent an error from happening. We also do, and then it's also important, like you said, a lot of nurses do sometimes to scan after the fact. So you want to do audits of that, in which you're watching the med pass to make sure that the medication's being administered after it's been scanned, in order to ensure that the correct medication has been given.
okay. And then from the chat, there's a question. What are your thoughts on keeping paralytics only in kits?
I think there's a lot of, I see the benefit of only keeping them in kits. I think that like at Jackson Memorial Hospital, it's so hard. We're such a large institution. We use such a high volume of paralytics. Having the kits, the maintenance of the kits is a lot of, there's a lot of room for error there, as well as there's a lot of hands that would have to touch it. You'd have to, and then it's a lot of time of preparing. So it really depends on your institution. How often are you using paralytics? And for us, there in our ICUs, we may end up having patients that get boluses that are not like RSIs. So should we only have them in RSI kits? Because then in the ICU, anytime they would have to give a bolus of a paralytic, they would have to open an RSI kit and then having that RSI kit replaced. So then thinking about the logistically, how many kits would you have to have in order to maintain this workflow is something that you'd have to take into account if you want to take that on. That's why I think ISMP made it an or of like having the kits or having them in locked lidded bins in the automated dispensing cabinets. I think there are a lot of benefits to the kits. I just think that they could be very labor intensive and there is room for error when you make so many of them as well.
I think it's, depends on what kind of kit you have it. So if it's an RSI kit, some places are also going to have midazolam in there.
Yeah,
So
so that's a good point.
again, it creates the same issue where you're looking at the vial and you just look at VE on the beginning of the vial, and
yeah, and then you're not even not even touching the fact that now you're having a controlled substance in the kit. So how are you tracking these kits? You have to like put them on count, prevent diversion from the kits, ensuring that the contents of the kits are being utilized. There's a lot of intricacies for that too. So I think there's a lot of benefits, but it's a lot to unpack and make sure you work through.
a lot of balancing.
Yeah.
Another question is, do you think better staffing requirements should be implemented in the med safety recommendations in the future?
I think that's a very loaded question. I think that it's a really I don't know if I've seen like staffing requirements, safety information. It wasn't something addressed, at least in any of the articles I've read, especially for this. I think that having safe ratios of nursing to patients is always something that needs to be taken into account. Just like we have safety ratios of pharmacists to technicians. I think that that's something that should be discussed, especially from like a nursing board standpoint. I don't know if that's something that ISMP will take on, but I do think that there's a lot of benefit to having safe ratios.
Yeah, standardization of ratios, I think, would be a good thing, because different hospital systems are likely operating at different ratios depending on your med surge, tele, ICU areas.
And it also depends, because like a smaller hospital, like some of our med surge floors can like at our hospital could end up being taking care of such still pretty critical patients. So understanding whether that's a safe ratio for your institution, for your patient population versus a different patient population at a smaller institution that has less critical patients.
And then you turn patients away if you don't have enough nurses.
Yeah.
That's and then a question from Nisha: what do you think of the hospital culture and not disclosing the event first? Is there a second victim resource at your hospital?
I think that, can you repeat the first part of the question? Sorry.
What do you think of the hospital culture in not disclosing the event first?
I think that speaks a lot to their reporting. I think that it doesn't show a lot of confidence in their just culture in handling medication errors and making sure that they that we're looking into the root cause of the error versus blaming the individual. And so it seems kind of from an outside perspective, because obviously I was not there to see what happened. But from an outside perspective, it can seem like shift blaming, but there could have been other factors at play that leads to them not disclosing it right away as well. And then our institution We have several resources for like counseling for all of our staff, and we refer like employee services. We don't necessarily label it as a second victim like resource, but anytime errors happen, our risk management does get involved, and then we do talk to the staff involved and ensure that they seek our resources and especially if they need them from how they feel from the incident that occurs.
And we've got one last question. Do you see a decrease of use in vecuronium in your healthcare system, and is there a better alternative to it?
So vecuronium, I think it depends on your healthcare system. Our hospital doesn't use a ton of vecuronium. We mainly use more atracurium. We have some vecuronium. We've limited our vecuronium to only being in ICUs. So not even for like RSIs really, just so I think there's a lot of like alternatives. I mean, when you think about like intubations using like rocuronium or succinylcholine, atracurium for drips. I've seen rocuronium for drips, but I think that there's a clinical benefit, risk versus benefit, and I'm not probably the best clinician. I don't work in our critical care area to say why one versus another. But I think the most important thing from an operational standpoint is making sure that you engage the clinical team to see the need of these paralyzing agents in all of the areas, and really trying to pare that down as much as possible.
Great. Well, thank you, everybody. I'm going to stop the recording now.